So let's get started. Yeah, there we go. The problem, there's a lot of people that can't see a screen because it's black right now. There's also a lot of people in the United States that have nasal obstruction. 6% of people, it's quite a bit. 20 million people out there waiting for our help. So let's talk about this. Karina, person comes in your office, I can't breathe through my nose, Dr. Levine, what do I do? So what are you interested in, not in, let's just stick on the history. What's key? What do you have to make sure to ask him?
So usually I want to know duration, history, location. So for me, I want to know what they have done, what worked for them, if anything, and I want to know a lot of the associated symptoms. Because anytime that you have somebody with nasal congestion, you could be thinking at something that's just rhinitis or rhinorrhea, but you could be thinking about a nasal tumor. You can also be thinking about something that's a sinusitis or polyps, or it may be somebody who says, well, for 2 weeks I've had an upper respiratory infection. So you really want a duration and a time frame, and then you want the associated symptoms to try to start narrowing that down.
All right, and I'm going to add to a couple things. Trauma is key, as you said, prior nasal surgery, especially prior septoplasty. You know, my enthusiasm and excitement to fix a previously operated septum goes down exponentially when I hear that they've had a septoplasty. What medications? It's really important these days to document that based on payer denials. And Afrin use. So if Afrin works on someone, that kind of gives you an idea where the obstruction is, right? Afrin's not going to straighten out the septum. It's going to help shrink the swell body and the turbinates. And then breathe right strips. If that works, tells you where that the nasal valve is a problem. And there are times where I'll say, well, why don't you buy a box of breathe right strips, see how it works? Because that's, if I'm trying to decide, am I going to address the valve or do I just need to stay internal? This is a key question to ask folks. Waleed, what's key on the exam?
Well, generally speaking, the thing I'm trying to differentiate is whether we're dealing with a structural problem or a mucosal problem or both. So the examination is going to look at the septum, and you're looking at all parts of the septum. So the caudal septum, the mid-septum, and even further posteriorly, although that's generally less relevant. I'm looking at the turbinate, judging degree of turbinate hypertrophy. So I'm doing an exam before I've topicalized the nose in order to evaluate the turbinate and turbinate hypertrophy in a native state. I'm also looking at the internal nasal valve area. So I'm trying to determine whether or not there's some level of collapse. And this is something you can do on anterior rhinoscopy or even with a nasal endoscope. It's also important, of course, to look at the nose from the outside, see whether there's any insufficiency of the lateral wall on inspiration, again, an indicator of potential internal nasal valve issues. Tumors, of course, and other potential contributors to nasal obstruction as well.
All right, excellent. So that's the traditional exam, speculum. Looks at the turbinates, anterior nasal masses, as you said. Challenge is it misses the valve and distorts the valve. So very, very important to look at tip support. Valve collapse, dynamic valve collapse is key. The caudal maneuver, that middle page, it tickles like crazy, but it's helpful to do, and then the modified caudal is nice. There was a survey done, and patients with nasal obstruction came in, and they asked the ENT where the different areas of obstruction were. And you can see there's a nice distribution between the septum, the inferior turbinate, and the nasal valve. I'll tell you what, before kind of recent history, the last 5 years, I didn't ask about the nasal valve very much. And why? Because it was hard to treat. I don't do functional rhinoplasty. And wanting to treat that patient, I just would kind of gloss over it. And that was a deficiency of mine. I worked with a couple really nice facial plastic docs in the region, and I would find myself referring the patient to them if they have valve collapse. But now we have some different options that we'll talk about. Winston, what about nasal endoscopy and a CT scan on these patients? How key is that for someone who comes in with nasal obstruction?
Yeah. So the easy answer for a CT scan is very rarely. Most of the times the endoscopy will tell you what's going on. So I think, as the previous speakers have said, a great history, especially when it comes to sleep and exercise. A great physical examination where you say, okay, I'm going to touch your nose, I'm going to feel your nose, I'm going to put my finger in your nose, I'm going to put a scope in your nose, and I'm going to look from front to back. And hopefully all of that done just with topical lidocaine, and then that's followed with topical Afrin afterwards. CT scans sometimes will be functional for trauma or for people with birth defects. So you're looking at the posterior nose to see if something narrows. But very rarely are we using CT scans for nasal obstruction. But the endoscopy is key. And that includes straight zero endoscopy, flexible endoscopy, and a 30-degree endoscopy with the patient speaking to make sure you look at the functional back palate of the nose to see how that moves.
Nice. And Sanjay, your practice is different being at Seattle Children's. What do you do with these wiggly kids, these 8-year-olds who come in and they just can't breathe through their nose?
I operate on everybody.
Of course, but before you operate, what do you do?
Oh, okay. Well, I think I do functional rhinoplasty for a lot of adolescents and sort of middle-aged children, and the exam is everything that everyone's mentioned so far. I think asking permission to touch the nose and is really helpful, and feeling the cartilages, the middle third of the nose, looking at the upper lateral cartilages as they relate to the internal nasal valve, and checking for the laxity of the lower lateral cartilages can be really helpful. I think you showed a great picture of someone with alar collapse. I really ask them to sniff in front of me so I can see the nose functioning in front of me. And then I'm a big fan of flexible endoscopy, and I don't do rigid in kids. And I find that for me has been successful because I can move it around and look at the internal valve and go all the way back. I think sleep apnea is much more prevalent with nasal obstruction in children. Well, maybe not, but it seems to be a high prevalence, and so I'll consider polysomnography in children in decision-making, because I like to have some objective parameters to justify, especially younger children, deciding whether or not to move on to surgical indications. So those are some things I'm thinking about.
And quick show of hands of you in the crowd, who does a nasal endoscopy on a nasal obstruction patient routinely? Okay. You know, it's interesting. This is what it looks like up front with a nasal speculum. Well, you know it's an endoscope, but that's what it looks like up front. And you look a little bit further back, and there's a big JNA. This patient actually had a septoplasty by somebody, and the patient still had unilateral nasal congestion after the septoplasty and came to me. So, this is the N of 1 that convinced me, yep, every patient with nasal obstruction needs a nasal endoscopy, some type of imaging, but nasal endoscopy. Here's another patient I had just last week who has a nice, maybe a Thornwald cyst. We'll see what it shows on path, but that nasopharynx mass was in their back of the nose, and interestingly, he only had obstruction when he laid flat. The CT scan, this is really just as Winston said, if you're thinking about chronic sinusitis. It does a really nice job, though, looking at the septal swell body. That's where the green arrow is pointing to. So what do we do? There's so many things we can do. Fix the septum. We have a lot of different ways to play with the turbinate, the inferior turbinate. We can use RF treatment now. The coding is sometimes challenging with different payers now, but it's something we'll talk about in a couple more slides. And then the implant for the nasal valve is quite nice. And I'm trying to stay away from name brands for the interest of CME, but we know what we're talking about. And then sometimes you just have to bite the bullet, and someone walks into your clinic and you're like, yep, you need a rhinoplasty. So one of these days, our friends may have it. But on that, so here is, let's go back to Dr. Levine. 44-year-old female comes in, her nasal valve is nice and strong. She has just mild improvement with the caudal maneuver. You look in her nose with the endoscope, and this is what you see. So she's already failed medical management. What are you gonna recommend for her?
So I think that the first thing for anybody is to understand how much it bothers them. So for everybody, when it's nasal obstruction, I don't see something that is a more serious disease. We've rolled out nasal masses, all of the other things. Then I start talking to them that this is really about quality of life. That's a little bit different if it's impacting use for CPAP for sleep apnea, but otherwise this is really a quality of life surgery or a quality of life procedure. So when I talk to patients with nasal obstruction, I talk through the different options. There are radiofrequency turbinate reduction options. That's probably not what I would choose here. I don't think that it would give the patient the best outcome because it's really a minor reduction. Provided that this patient could have a surgery, I'd probably recommend addressing the turbinate and the septum. I would talk through what that's involving. If they don't have any nasal valve collapse, I think that that would be a reasonable thing. We talk about whether or not it's anterior enough to have an impact on their appearance. And I also talk about what the risks are involved with the surgery and what the recovery is. There are lots of patients who decide then, you know what, I could live with this and I don't really want to do anything. And there are many patients who decide, no, it's really bothering me a lot and it's worth doing it. But I think understanding how much is bothering them is probably the most important first thing, because you want to set appropriate expectations. And if you only think you're going to get a mild improvement, it may not be worth doing a surgery. But based off of the image, I would probably talk about a septoplasty and a turbinate reduction.
All right. 1 or 2 turbinates? Oh, wait, before you answer. Panelists, who's going to do both turbinates? Raise your hand. Who's going to do 1 turbinate? Raise your hand. Who's going to do no turbinate? Raise your hand. All right. Karina?
So the way that I would assess it is if they respond to Afrin. So if this patient is sprayed with Afrin and feels that there is improvement in breathing in one side or both sides, that's how I would determine what I would offer them.
Okay. Any harm in outfracturing that left inferior turbinate? Sanjay?
I don't think so. I think that outfracture tends to be pretty easygoing. I want to say one thing about the Afrin test, that it's a great idea. I've noticed, though, with the septum that's turned over and pushing on one ipsilateral turbinate, I don't know why, there's a larger turbinate on the other side filling that deviated septum. So it's unusual for me to see just, it's almost like there's one that's smaller on the side that's deviated and the other side seems to be bigger. And that looks like that on imaging too. So it's rare for me to just do one side, it's got to be a unique situation. It's almost always bilateral. Outfracturing, I don't do a lot of turbinate reduction in my practice, but I think it's okay. I don't know.
Wally,
We should ask the malpractice expert, actually.
I have a next question for Winston. Not yet, though. He's muted for this question. Wally, what about you? Anything different?
No, I think the other panelists have touched upon it. What I'd like to evaluate, the compensatory hypertrophy you see on the right, for me, it clearly has to be addressed. Typically through some form of reduction. I like to use a submucous resection of that right-sided inferior turbinate followed by outfracture. And then frankly, it's kind of a game time decision. So I do consent the patient for bilateral turbinate work. And I'll address the septum. I'll look at that left inferior turbinate. I'll see what needs to be done. Sometimes I don't feel that I actually need the submucous resection on that side, and then I'll just do a mild outfracture. That typically works.
Okay, so what do you mean game time decision? Because odds are by the time the patient is on the OR and you're looking in the nose, they've had a couple doses of Afrin.
Yeah, no, that's a great question. And the rationale that I have is, so once you've straightened out the septum, I can actually judge the distance between the inferior turbinate and the septum at that point. If it looks like there's actually a reasonable gap there, even in a topicalized nose, I'm not really going to touch it very much. Like I said, I'm not going to do submucous resection. There are potential consequences to over-resecting submucosal tissue in the inferior turbinate. And so I play it conservatively and perhaps just lateralize the inferior turbinate a little bit. And like I said, it tends to be quite effective.
Okay, so I have been involved in a clinical study looking at a device, and one of the things we have to do is grade the turbinates before decongestion. So it's really forced me to look at the turbinates before I do anything. It's interesting how much the Afrin will work and change our opinion intraoperatively. It really, I feel you need to commit to it before surgery and have a plan based on that non-decongested turbinate. I think striving for symmetry is key. And looking in that nose, you want to make things as equal as possible. Patients will complain if there's asymmetry. Even if both sides are a lot better, they're going to be like, well, yeah, I breathe a ton better, but the right side's not as good as the left. How come, doc? So I don't think there's anything wrong with addressing both inferior turbinates. I think that for me, that's the goal, is to make symmetry. Winston, I have a tough one for you, though. Being in California, I need your help with this. The caudal septal deviation. If there are like 2-3 tricks to fix this, and you can see the septum is coming off the crest right here, but it's going all the way to the caudal septum, which I don't have a picture of on this one. Do you have any hints for us to help straighten that out? And referring for facial plastic functional rhinoplasty is one option for sure. Anything else short of that?
I'm amazed how many people had rhinoplasties because they had their face on Zoom this year. Mm-hmm. Rhinoplasty, if you have any facial plastic colleagues, they have all done extremely well during the COVID pandemic because everybody's been looking at their face going. So if there's a caudal deviation and I think that I could make that patient worse, I refer them to my colleague to do the case jointly with me or just have them do the the case independently. I think what's really, really cool is that most patients, including myself, have a caudal deviation. And we look in the nose. If you go back to your previous patient, there are procedures that you could do even in this patient that do not involve the operating room that we can offer these patients. And nasal obstruction has become super sensitive topic for patients. There are these books about breathing and these yoga things, and you're going to improve your health just by breathing better. And I'm finding that a lot of people are expecting something like what Afrin can do. And I never use Afrin as the gold standard because I've never really been able to get a patient as good as Afrin. And so I usually say, I can get you 70% Afrin, but I'm not going to get you 100% Afrin. And the same thing with the rhinoplasty surgeons is that they will get lots of support, lots of stability, but it's a huge road to walk for nasal obstruction improvement to have a full-on rhinoplasty. For the caudal deviation patient, I can often get their turbinates reduced in the office with office-based procedures that I say to them, I'll get you to see the rhinoplasty doctor after he or she's given you the spiel, come back to me, and then we'll decide together what to do next. And quite often the patient will come back and say, give me 70% Afrin somehow in the office because I do not want to have that procedure done.
Great point. Sanjay, let's say this patient is a 14-year-old male. What's the latest teaching for doing septoplasties on youths?
So, I think it's we're still struggling in peds otolaryngology about the indications for pediatric septoplasty, and I'll disclose that I may be a little bit more on the liberal side of that pendulum. Just in my sort of experience, I haven't had anyone have, and I should just say this anecdotally, I have not had anyone have any tip support problems or facial symmetry or saddle nose deformity. And the long-term anthropometric studies looking at groups that have long-term assessment, there really is no stenting in facial growth in children who have undergone rhinoplasty, skull-base surgery with vomerectomies, et cetera. There's some animal studies in guinea pigs that suggest the opposite, particularly from a group in Netherlands. So it all depends on whether you believe there are centers of growth in the nose or not. And if you think there are, then if you remove a center of growth, it'll affect things. I am not on that plane of belief. I think the nose grows diffusely. There are no centers. And so therefore, I have a low threshold for intervening for a child or adolescent that has poor function of the nose. If they are suffering, and most of the kids, I'm not taking care of like a subtle little thing. Most of my kids have a jacked columellar deviation where the septum's sticking out into the external valve, and I have lengthy discussions about functional surgery. And I almost all those types of cases I do through an open approach. I do a columellar incision, lift flaps, divide the lower lateral cartilages, and my tricks for you are I remove almost no cartilage. I just relocate. I get it to a point where it's a swinging door along the maxillary crest. I don't take out a large central portion. I'm thinking about the next surgeon down the road who needs that for alar grafts or for batten grafts in the future. So my goal is to just trim off the floor, get it swinging, and then I reapproximate it right to the right nasal spine, and then I close the lower lateral cartilages around the septum, and that's my septoplasty. And I offer families that, and I give them a 5% chance for revision surgery. I coach them. I prefer to wait till they're fully adult size, 15, 16, but if the function's poor, I'll go earlier, and sometimes we do polysomnography testing to figure out if it is or not. I don't have any head-out plethysmography or acoustic rhinometry in my armamentarium to really test objective measures, but that would be another choice as well to sort of with your decision-making.
Okay, thank you. There's a couple ways to skin the cat. It seems like every year there's a new technique. We do have several different versions here in the lab tomorrow. I encourage you to ask the reps if you can try different things. Anything you see here in the dry lab, you can use in the wet lab. So please give everything a shot. The one thing I want you to remember is there are litigations, especially about inferior turbinate reduction. Winston spoke about this, and I just want to highlight, this is a study we did just last year or so. Quite a few cases, especially down in California, so heads up, my friend. But the claims were surgery was not indicated, not documented. Surgery was negligent, And there was a lack of informed consent, lack of signed consent. So, we should really be getting consent, and that's where patients did pretty well. Fortunately, the surgeons are the winners, if you can even call them winners in these cases, but the idea is to avoid it. So where I did additional training in Australia, I have changed my technique quite a bit. They take quite a bit more turbinate tissue out, and now I am preserving most of the turbinate and really trying to just get that submucosal resection, trying to leave the outer tissue all intact. This is a nice system. Show of hands, who's used this RF system? Wow, nice. All right. You definitely got to get your hands on it tomorrow. It's worth trying. This is something that is very, very nice to do in office. I have sometimes used this as a stepping stone prior to surgery. I rarely have to do this followed by a septoplasty turbinate reduction because this works really well. It targets the nasal valve collapse, the inferior turbinate or the vestibular swell body. This cartoon kind of looks like that. And then the septal swell body. One of the hardest places to treat is that septal swell body. It's a pain in the neck. It's there, we know it. You're doing a septoplasty. You don't want to cauterize that tissue if you don't have to because you get a little concerned about the perforation. They have really nice 6-month data. And Moshe did this study. They showed a significant reduction in nose score. So 69% of people improved, and improvement is basically 20% improvement on the nasal obstruction score. So really nice data that shows a big improvement. And then they did a follow-up study 2 years out, and nearly everybody kept their results for 2 years. So, okay, this isn't just a 3-month thing. This is a lasting procedure that's easy to do in the office. And the other thing that has come out, and we're going to show you a couple examples of the other thing that's come out is this other absorbable stent. Almost lost it there. That was close. We can say it out loud. This is Litera, and it's the only one that's available. It does have a CPT code now, which is pretty nice. And the data behind this, so they did a really, I love this study. It's a sham study. So some of the patients got the actual device, and some of the patients just had the procedure. So sliding the cannula into the nose and then withdrawing it without putting the device in. And the treatment side, 82% had improvement versus 55% of the sham side. So it still does kind of stiffen up that valve nicely. There are some low risks of complications, implant extrusion where you have to go back in and take it out. It's a very easy thing. I've been told to do in clinic. I haven't had to do it in clinic yet. So 4% risk is what I tell my patients. Very few people have pain. Some people can have a foreign body sensation, especially if they wear glasses. And so if you do decide to do this procedure, I encourage you to speak with your Stryker rep. They have a very nice head model that gives you some practice on. Sonia's in the back, and she's happy to. Did you bring it today, by the way? Great. So that's something that you can try out. It's a great way to treat the nasal valve, and there's some interesting times. So here is a case in our final minute or so. We'll go through these. 19-year-old female, is heading off to college real soon, a really stuffy nose, gets some nosebleeds as well. She has a pretty straight septum, large turbinates, and this is what she looks like when she has inspiration. This is my daughter. And so she gave informed consent to videotape her. Thanks, Claire. But she's collapsing pretty good. So one of my colleagues at work did a turbinate reduction on her and did a little cauterization, and she had a great result. Winston, what would you do with this 49, pretty darn close to 50-year-old guy? Nasal congestion, really when he exercises, doesn't have time to recover from surgery, mild septal deviation, allergies are well controlled. So you can see some decent valve collapse there. This is me, by the way. What would help me? Yeah, I mean, give me a hand.
I think that he's going to have a facelift because
I know. Look at the bags under my eyes.
That's collapsing. It's not just the nose. You can see that he needs some fillers.
I'll just sign over December to you.
It's a mid-face surgery he needs.
So looking at this, I think this is this or me is a really good option for the in-office RF procedure because I'm not super excited to have surgery. I'm kind of a wimp with pain. I don't know if I want to go through a Litera Awake maybe, but it's a stepping stone to the next step. Unlike this guy, one of my other partners, he has a lot of bad breathing through his nose. He just wants to breathe. And this is him. And I wish I had the audio because there's this high squeaking noise every time he breathes through his nose. So he was on the schedule for little subtoturb and Latera. We'll see if that happens by the end of the year. But I don't want to go over time. There's a lot of stuff we could talk about. This is an update. And I encourage you to seek these two relatively new things, the Latera and the RF, which is by Aaron Medical. Give it a shot. And they do help our patients. And from my practice, it has kept them away from the facial plastic surgeons. Any questions on any of this before we jump into the next talk? Thank you for the friendly discussion, my friends.